going forward and talking about another type of obstructive disease, chronic obstructive lung disease, here's a 67-year-old woman with COPD who is evaluated for dyspnea. She denies fever but has productive cough. Her medication is inhaled ipratropium. She has 32 pack years of smoking history. Her respiratory rate is 32. Her pulse is 106, and she's febrile. Her physical exam, she's cachectic. She has rapid breathing, distant heart sounds, increased AP diameter, and expiratory wheezing. So this is typical. And this is typical of a patient, and we're going to talk about these patients and then go back to this case and talk about it again. But this is a typical case of some type of chronic obstructive lung disease, and in this patient, just because of the way she looks, her rapid respiratory rate, that she looks cachectic, she doesn't look plethoric, that usually the diagnosis that these patients have, especially when they don't have the productive cough many months out of the year, usually the diagnosis she would carry is emphysema. So, but let's talk about these diseases, and then we'll go back in this case and discuss it again. So the general concepts are that there's two types of chronic obstructive lung disease: emphysema and chronic bronchitis. Emphysema is really a pathologic diagnosis in terms of the definition means permanent dilatation of the alveoli, from the terminal bronchiole to the alveolar membrane. Permanent dilatation and destruction of both the terminal bronchioles and the alveolar membrane. And once these patients develop permanent dilatation and destruction, that's when the DLCO gets affected, versus other obstructive diseases like chronic bronchitis where the DLCO is not affected. Chronic bronchitis, on the other hand, is a clinical diagnosis. Most of these patients have productive cough 2-3 months out of the year for consecutive years. So even though both of our chronic obstructive lung diseases, one it's more of a pathologic diagnosis in terms of the definition of it, and chronic bronchitis is more of a clinical diagnosis. The definition more so for both COPDs is that they have non-reversible obstruction. So when you compare these diseases to asthma, for example, the bronchoconstriction that affects COPD is basically permanent, non-reversible. When I give these patients bronchodilators, I see no change on the PFTs, or the change in the pulmonary function test is minimal. Maybe about 2, 3, 4%, but never more. Minimal. Also, these are non-inflammatory conditions. Unless you're talking about a COPD exacerbation, in the chronic state, chronic obstructive lung disease is a non-inflammatory process. Compare that to asthma, which we said by definition is an inflammatory process. These are non-inflammatory. So these patients don't benefit from chronic use of steroids. Now, there is a small population of these patients, and they're sometimes referred to as asthmatic bronchitis or inflammatory bronchitis, where they have reversibility and they have inflammation, and you could use steroids, but for your purpose, across the boards, COPD is a non-inflammatory condition in the chronic state. That's not the case, though, when they come in with exacerbations. So we have recent studies in the last 7-8 years that show that when these patients come in with an acute exacerbation, I mean when they come in with worsening of dyspnea, they come into the hospital with shortness of breath and hypoxemia and so forth, that at that time, during the acute exacerbation, there's a component that is very inflammatory. Thus, we know that we use corticosteroids in that acute setting to resolve that inflammatory process, but not in the chronic state, only in the acute exacerbation. Cigarette smoking is the main culprit of COPD, and most patients will get it usually in the 6th or 7th decade of life, because it's usually after 30 years of smoking and more that we see evidence of chronic obstructive lung disease. Not all patients that smoke get COPD, so there's other factors here. These people are definitely predisposed, but most patients with COPD, cigarette smoking is a factor. And then we have a rare form, but something that we have to look for because it may be treatable. A form of COPD usually causes emphysema, usually emphysema involving usually the lower lobes mostly, in young patients that may have a short smoking history or no smoking history at all, and this is called alpha-1 antitrypsin deficiency. If you're missing your alpha-1 antitrypsin, you don't block these enzymes in the lung that cause chronic inflammation and destruction of the alveolar membrane, and these patients develop emphysema eventually. They're younger patients, so you'll see, a 40-year-old person or a person in their 30s get emphysema. You have to think about this disease. These patients also, we're going to talk about it a little bit later, these patients also develop liver enzyme elevations, transaminitis, because when you have alpha-1 antitrypsin deficiency, these patients develop also a form of hepatic inflammation, hepatitis. So the presentation is straightforward. They have chronic wheezing or intermittent wheezing. They have dyspnea on exertion. This is probably the main complaint that they come to the doctor for, the hospital, and they have productive cough for a few months for consecutive years. That's the typical chronic bronchitis. Patients with emphysema usually don't. They may have a little bit of cough, but they don't have that consecutive for months and months productive cough for years and years. That's the chronic bronchitis, and that's why when we looked at this case, the COPD case that we just did, I said, well, I don't know the diagnosis yet, but it's more likely consistent with emphysema. On the physical exam, what do you find? Well, if they have hyperinflated lungs, you find distant heart sounds, and they mostly do. You may find some bronchi and wheezing. Because these are chronic diseases, when you look at their fingers, you may find clubbing. If the disease has been going on for a long time, it affects the pulmonary hypertension, affects the right side of the heart, and it causes choropulmonality, right-sided heart failure due to pulmonary disease. Now that's a big, big deal, because now once a patient develops choropulmonality, their morbidity and mortality increases exponentially. So that's a big deal to try to prevent choropulmonality from pulmonary hypertension, and we'll talk about that in a little bit. And the last thing that I put down here, because they may ask you a question about that, a lot of the patients, and especially patients with chronic bronchitis, develop a facial plethora, like erythema around their face. And the reason for this is because their hemoglobin and their hematocrit is elevated. They really look really rosy. And the reason why is because they have secondary erythrocythemia. Not polycythemia vera, secondary erythrocytosis. And the secondary erythrocytosis is the most prominent factor, is the chronic hypoxemia, hypercapnia that affects these patients, and probably because a good number of these patients are smokers also at the same time. So if they ask you, what are you likely to find on the hemoglobin hematocrit in these patients, the answer is, I'm likely to find a hemoglobin hematocrit that's elevated. That's what I expect to find, somebody that has chronic bronchitis. The chest x-ray is typical. The hyperinflated lungs, the flattened diaphragms, and especially in emphysema, the slender heart that we see. In the ABG, hypercapnia, hypoxemia, the thing to remember is that these patients, especially the patients with chronic bronchitis, fall into that 60-60 group. You know that their CO2 is equal to their O2, right? 60 of CO2, 60 of O2. That's the typical finding. And sometimes if you give them too much oxygen, in this case, they retain CO2, right? So you get concerned about that low O2, and then you give them oxygen, and you kind of blunt their respiratory drive and they retain CO2. Now that's not, I said blunt their respiratory drive. It's not exactly what happens, but these people retain CO2 when you give them too much oxygen. The labs, we talked about the polycythemia and the pulmonary function test. Every patient with COPD, every patient with asthma has to have PFTs. I've stressed that. These show non-reversible obstruction. If a patient has emphysema, he or she will have non-reversible obstruction plus a decreased DLCO. A patient with just chronic bronchitis will have non-reversible obstruction with a normal DLCO. In clinical practice, most patients fall into a category where they have a little bit of emphysema and a little bit of chronic bronchitis. You don't see this clear-cut picture that I just talked about, but we need to know this for the exams. We need to know that a patient with emphysema, if they have only emphysema, has DLCO that's decreased, and a patient with chronic bronchitis has normal DLCO if they have only chronic bronchitis. And then they look a little bit differently, I told you. Patient with chronic bronchitis has the productive cough, looks plethoric. Patient with emphysema doesn't have productive cough, looks a little bit cachectic. So those are the big differences we have to remember for the exams. So how do we manage these patients? Well, on a chronic basis, we have to give them bronchodilators just like we did with the patients with asthma. And the drugs of choice now are the anticholinergics. Remember, the anticholinergics don't work too well with asthma or asthma exacerbations because we need quick relief medication in that case. Well, here they work better because they're longer acting drugs, right? They don't give you that quick relief right away, but they act longer. And also because they don't have a lot of side effects. Remember the beta agonists? Well, one of the things that they do is they cause tachycardia. Now, if you give it to an asthmatic patient, young, otherwise healthy patients, the beta agonists don't bother them. But in these populations, they got subclinical heart disease, you give them a beta agonist and you cause tachycardia, this may affect them. So the first line drug in chronic obstructive lung disease, the preferred drug is inhaled ipratropium, and that's the way we start off with. We may use beta agonists along with that. In fact, some of these, the inhaled systems they combine both the beta agonists and the anticholinergics at the same time. But generally, if they ask you what is the most effective bronchodilator in these cases, then the answer is ipratropium, anticholinergics. Beta agonists we add on or we use as a secondary drug, especially because they have a little bit more side effects. In this population, these people have a lot of comorbid conditions. Theophylline is a big deal lately. Now, theophylline has gone through different phases. Everybody was using it 30 years ago, 10 years ago, people fell out of favor. Nobody's using it. Now people are starting to add on, again, because they see that theophylline is a great drug in terms it makes the patient feel better. It is not a great bronchodilator, but it has some other effects. It has a cardiotonotic effect. It helps with retraction of the muscles, the diaphragmatic muscles, so your diaphragm works better for breathing when you use theophylline. So it does a lot of other things that the patients find to be beneficial. Bottom line is this: add theophylline only when the other treatments don't prove to be as good. So let's say you put the patient on anticholinergics and then you add beta agonists and the patient still has symptoms, then you say, okay, let me use theophylline. A word of caution: if a patient's taking theophylline already, it's probably best to let him or her continue the theophylline. Once the patient has been using theophylline, they feel better. If you take them off the theophylline, they feel it right away. And they feel like their lung disease got worse. Even though it doesn't decrease morbidity, it doesn't decrease mortality, it does none of these things. So we're going to talk about a little bit later what things do decrease morbidity and mortality. Despite not doing all that, the patient feels much better. So if a patient is taking theophylline, let him or her take theophylline, continue to take it. If they're not taking theophylline, hold off. And if the rest of the medication doesn't do anything, then add on theophylline. Please be careful because theophylline has toxicities. And it also has a lot of side effects when you combine it with other medication, especially mycin antibiotics. So there is you increase the levels of theophylline when you put somebody who is already on theophylline on erythromycin and other mycin antibiotics. The other mycin antibiotics is not as bad as erythromycin, but you have to be very careful about theophylline toxicity in these patients. So be careful of that. Also, theophylline levels are decreased in patients who smoke. So they ask you sometimes, well, you know, your COPDer who has stopped smoking 3 years ago now comes in and feels worse, and the theophylline seems to not work. And it was working in the beginning, they felt really good, and now it stopped working. What do you think about in these patients? And the answer is they started smoking again. Very interesting, but smoking decreases the levels of theophylline, so they get subtherapeutic levels in these patients. So what things then increase survival? So this is a big deal. What increase survival? Well, if bronchodilators don't, theophylline don't, what do? So there's only two things, basically. Smoking cessation is number one. If you stop smoking, that's the most important thing in survival in these patients. If they stop smoking, and then the second one, if they have significant hypoxemia, they get home oxygen supplementation. The home oxygen supplementation is basically therefore to reduce the pulmonary hypertension that's associated with the hypoxemia and the hypercapnia. So what do we do in these patients? We tell everybody to stop smoking, and then we give them home oxygen only if they have severe and significant disease. When do they have significant disease? When we measure their oxygen, their resting oxygen, right here, and it's less or equal to 55. Anything equal to or less than 55 resting, a PaO2 of less than 55 or equal to 55 resting, that patient gets home oxygen. And then there's one more category of patients that have a PaO2 of less than 60 or 59 or less, of PaO2 of 59 or less, but they have right-sided heart failure. Those patients deserve home oxygen. So if they tell you somebody has a PaO2 of 58 at resting plus JVD, lower extremity edema, they're trying to tell you that this patient has cor pulmonale. Give them home oxygen. A third category, which they haven't asked a lot about, are certain patients where when we measure them under normal conditions, resting conditions, their PaO2 is usually normal, above 60. But then they tell you, when I walk across the street, I get really short of breath. I have to stop a million times. And some of these patients desaturate with exercise. So you give it to them only when they have to exercise. And how do you prove that? Make them walk up a couple flights of stairs, right, and measure their ABG, and now you find that PaO2 is 50 after just a couple flights of stairs, and you tell them, okay, you fit the third category, desaturation with exercise. Take home oxygen, use it only when you exercise. These two categories here, less than 55 and less than 59 with cor pulmonale, those patients should use home oxygen as much as they could, 24 hours if they can. That's better than anything. If they can't use 24 because they hate to do it, tell them to use it 12 at least, or 18, as much as they can. The more the better. The most important time to use it is, they may ask you this, what's the most important time? When do people desaturate more? When do they get more hypoxemic? At night. So if a patient says, look, doc, I could only use it a certain time during the day, tell me what time and I'll use it. Tell them use it at night, because that's when they get the most severe hypoxemia. So we talked about smoking cessation and home oxygen for certain of these patients, not all of them, if they fit the criteria, as the two main ways to increase survival and reduce morbidity and mortality. And then the third one, which makes sense and everybody almost does, is to give these patients certain vaccines. Remember, one of the most common reasons for exacerbations that patients come into the hospital with COPD exacerbation is pulmonary syndrome, pulmonary infections. So it is very, very important for these patients to get the influenza vaccine, the viral influenza vaccine yearly. This is given every year. And then they get the pneumococcal vaccine every 5 years, they say now. Some people say once in a lifetime, but just to be sure, people that are relatively immunocompromised, you may want to be sure by giving it every 5 years. But if they say pneumococcal vaccine once in a lifetime, that's adequate too. And then the Haemophilus influenza vaccine, the bacterial Haemophilus influenza, once in a lifetime also. So make sure that these patients get their vaccines, and this goes for all patients with chronic pulmonary disease. That's the most common reason for them to have exacerbation, is for a person with chronic pulmonary disease to develop some kind of pulmonary infection, wind up in the hospital. We can't take care of all of them, but the ones we can are the most common ones. They're right here. The viral influenza and the pneumococcal vaccine, they have to get that. What do we do in the acute exacerbation? Somebody coming in with an acute exacerbation. So they tell you, well, I was doing well all this time, and all of a sudden now, the last couple of days, I got really short of breath. I started to produce cough and stuff like that. And then they come in, and then, you know, they're hypoxemic, and this is a typical acute exacerbation of COPD. Now, this is, in a lot of patients with severe lung disease, with severe COPD, they come in 2, 3, 4 times a year into the hospital with a COPD exacerbation. Very common, especially in the winter, the fall months, with the viral syndromes in the lung, lurching around. So very common scenario. So what do we do? Well, the first thing is assess the severity of the hypoxemia. We always do an ABG. And then the second thing is to do, along with that, continue with monitoring their oxygen saturation, right, by pulse oximetry. We be careful, because remember, the first thing we do in an acute exacerbation, always, we give them oxygen, right? So here it is, right at this point right here, we give them oxygen by nasal cannula, right? This is the first thing we do in anybody that has dyspnea and shortness of breath and hypoxemia. But in these patients, and we're going to talk about it also a little bit later, in these patients it's very important to keep the pulse oximetry, the pulse ox, the saturation of oxygen, between 88 and 92%, and not go above that, because the fear that you're going to cause a CO2 retention in these patients, because you basically blunt their respiratory drive. As I said before, it's not exactly that we blunt their respiratory drive, but it probably has to do more of a VQ mismatch in these patients. But the bottom line is, if you give them too much oxygen and continuously keep the pulse ox above 95%, these patients may retain CO2 and get confused and so forth. So give oxygen enough, to 88 and 92%. Remember, you don't withhold oxygen in a patient that's hypoxemic just for the fear of causing, CO2 retention. Please be careful. They've tested that. Please, you don't do that. You give enough oxygen for the patient to have 92% saturation. Even if you have to give 5 liters, even if you have to give 6 liters by nasal cannula, even if you have to intubate the patient. So first and foremost is keeping the patient's oxygen stable. And then the second thing is, well, make sure you don't keep it too high in these patients, because you fear the chance of CO2 retention. We always do a chest x-ray in these patients, and the reason we do a chest x-ray, as the case of asthma, we don't do it to diagnose COPD, but we do it to exclude pneumonia and other lung processes like an effusion that would worsen COPD, or atelectasis, and so forth. If there's any evidence of an infiltrate in these patients, please assume that it is bacterial pneumonia and treat it as such. Theophylline levels, please, if the patient's taking theophylline levels and you put the patient on macrolide antibiotics, be careful about theophylline toxicity. A couple of other things. We do a CBC to look for leukocytosis. We do a chem profile to make sure the patient doesn't have any electrolyte imbalances. Sometimes because they have edema, they're taking diuretics and so forth. And we do an electrocardiogram to exclude any arrhythmias that would have worsened COPD, like heart failure and stuff like that. So where do we go from there after we do the basics? We always admit to the hospital if there's changes in CO2 or oxygen that are significant. So if this patient, his CO2 is usually at 50 and now his CO2 is 65, that's a significant increase in CO2, and you're going to see that with the pH. There's going to be a significant drop in pH. The same thing with the oxygen. If this guy is, his oxygen level is usually in the 60s, 70s, and now it's in the 40s, that patient, he or she has severe symptoms and have to be admitted to the hospital. Any patient that you suspect pneumonia, so they have fever, they have greenish cough, and they have COPD, you can't discharge that patient home from your office. You send them to the hospital to be looked at for at least a couple of days until things settle down. All patients with COPD exacerbation means that they have severe COPD if they're taking home oxygen. If they have a COPD exacerbation, generally admit them to the hospital to be observed. So if right away the guy comes in and says, listen, I have productive cough and I don't feel good and I have dyspnea, and the first history you ask him is, do you take home oxygen? Because that's going to make you admit the patient right away. That tells you that this patient has severe disease and doesn't have a lot of balance in his lung, is not able to is easily compromised if they have hypoxemia, any further hypoxemia. If a patient with COPD has any altered mental status or is hemodynamically unstable, this patient has to be mechanically ventilated and before that intubated, of course. Some patients, some doctors from some old literature think that if you intubate a patient with chronic obstructive lung disease, it is very difficult to extubate this patient and so forth. It may be right, although some of the recent studies show that that's not the case, that likely they get extubated as well as other patients. But even if that was the case, these patients have to be intubated to protect the airways, if they have altered mental status or if they have any hemodynamic instability. We talked about O2 supplementation. As soon as you do the ABG at room air, as soon as you put on the pulse ox to monitor this patient, give them O2 supplementation and do it to around 90%. I put 90% here, but it's usually 88 to 92%. Try not to go consistently above 95% because you may blunt the respiratory drive. Bronchodilators here we use a lot of, but it's more of the ipratropium kind, because you're not going to see, much of a reversibility in this patient. Remember, chronic obstructive lung disease is permanent. It's not reversible. The reversibility that you get in these patients is 5%. In some patients, 5% reversibility makes them feel much better. That's why we use the bronchodilators in these patients. But generally speaking, they're mostly non-reversible. As we treated the asthmatic patients, you could give a meter-dose inhaler or a nebulizer treatment, whatever is preferable for the patient's condition. Both of these work well in the acute setting as long as the patient knows how to use them well. Systemic steroids, now here's the big deal. Over the last 10 years, here it is right here, systemic steroids. So what do we do now? We treat an acute COPD exacerbation as an inflammatory process when they have an exacerbation, just like asthma kind of. We give them a spurt of steroids. We give them a high dose and then we taper it off over 10 to 14 days. The reason is because we said COPD in general is a non-inflammatory condition unless you're talking about the acute exacerbation. Studies have been done in this case and have shown that the patients do much better when you treat them with steroids in the acute exacerbation. The second big thing that has changed over the last 5 to 6 years is right here. Studies have shown that even when a patient has a normal chest x-ray who comes in with COPD exacerbation, you will benefit these patients if you put them on antibiotics. Why? Because a lot of them probably have some form of bacterial infection that you're either not seeing on the chest x-ray or you're not getting enough symptoms to make a clinical diagnosis. The patients that will benefit the most are the patients that have purulent, productive cough, fever, clinical signs of pneumonia. So those are the people that are going to benefit the most, but the studies have shown that even if the patient has minimal symptoms, if they come into the hospital with an acute COPD exacerbation, you treat them with antibiotics even if the chest x-ray is normal. What are good drugs to start off with? Well, think about it. Things that treat gram-positive common infection and some of the atypical bacteria like chlamydia, like mycoplasma, like legionella. Those are the common culprits. Strep pneumo, right? Haemophilus influenza, right? Those are the typical bacteria. And then the atypical, chlamydia, Legionnaire's disease, right? And so forth, and mycoplasma. So you want to cover both. So good drugs are things like clarithromycin. Azithromycin is probably the best single agent to use. Azithromycin. A lot of people like to use that lately. And some people like to use cephalosporins. Some people like to use cephalosporins if the patient has severe exacerbation of COPD along with a macrolide. So a cephalosporin like ceftriaxone, you're getting great Haemophilus influenza coverage, you're getting great strep pneumo coverage, and then the macrolide covers the atypical stuff. And then a newer study that has come out in the last couple of years where if you use the new fluoroquinolones, the extended spectrum fluoroquinolones, some people think now that these are, as a single agent, close to replacing almost everything else. So now you see in hospitals, when a patient comes in with a COPD exacerbation, they'll put him on one of the newer generation extended fluoroquinolones, right, because they cover both gram-positive and atypicals. So these are the kind of drugs that they may ask us about what to use in a COPD exacerbation. So again, when the patient comes in, we give them oxygen, enough, whatever that matters, whatever that means, enough to keep about 90–92% saturation. We give them bronchodilators, and then we give them systemic corticosteroids, a taper of systemic corticosteroids, along with antibiotics. We always use antibiotics now. A couple more things for the boards. Don't stop theophylline if the patient is taking it. We said this before. But don't start theophylline if the patient is not taking it unless you have no other choices. Avoid a couple of other things, sedatives, opiates, all these things reduce the respiratory drive. So you don't want to do that. It doesn't allow the patient to breathe well. Before the patient leaves the hospital, two more things that you have to do that they may ask you about. One is counsel on tobacco cessation. Before discharge from the hospital, they've done studies, and when the patient is sick, we used to think, well, you know, they're in the hospital, they're sick, don't bother them about tobacco cessation. But studies have shown that, you know, when they're sick, the patient actually takes it more seriously when the doctor says, listen, you know, if you stop your smoking, you know, in 10 years, you know, your lung is going to be back almost, you know, 10 times better. Not, you know, totally normal, but it's going to be much better. And, you know, this disease is going to halt. It's not going to get worse. And then the second thing along there, very important, is to counsel the patient on optimal ways to use the metered dose inhaler. It's all the time that we see patients where they're using the metered dose inhaler and they're using it wrong. They don't know how to use it. So it's very important to sit down with the patient and teach him the right, or teach her the right technique in this case. Those are very, very important things. The last two here, I guarantee you, this is going to be, you know, some kind of issue about a question, because it's very common things that we forget to do with these patients. So smoking cessation in the hospital and in the office, but in the hospital especially, and optimization of metered dose inhalers technique. So a couple more things. PFTs and COPD. Always confirm the diagnosis of COPD by PFTs. We said we always have to do that. But a little bit more that they've asked is, what is the best predictor of survival? How do I know a patient is got severe disease or mild disease or moderate disease? How, how does it correlate with the symptoms? And what's the best way to do this? And the answer is by measuring and looking at FEV1, I could tell you how bad this patient's disease is. So for example, if a patient says, I have an FEV1 of less than 25% of predicted, I know that if you make them walk across a big room really quick, they get short of breath, severe disease. They can't walk up a flight of stairs without stopping. If their FEV1 is between 25 and 50%, that's kind of moderate. They could walk, a couple blocks before stopping with shortness of breath. So it lets me quantify the symptoms and correlate with the disease. So I know, okay, this guy's FEV1 is less than 25%. He can't walk across this room without getting short of breath. So that correlates along with what I expect to see. Very important, because remember, these patients sometimes have comorbid condition. So this guy tells me I can't walk across the room because I get short of breath. I'm not 100% sure this is from their COPD. It could be from their cardiac disease. If I see a disconnect between their FEV1, right, and their symptoms, for example, if this guy has an FEV1 of 60% of predicted, and they tell me I can't walk across this room without getting short of breath, then I say to them, look, maybe we should start looking. This is not from your lung disease, it's something else. Start to look at, heart disease, other stuff. So please remember that. Patients that have a FEV1 of less than 25% of predicted, their survival is less than 5 years most of the time. They have a very dismal survival. So that's something that you may want to tell the patient, that they don't have a good prognosis, and the family. Don't do pulmonary function test after recent or during a COPD exacerbation. So I see patients all the time getting pulmonary function tests in the hospital. There's no reason for that. You only do pulmonary function tests to diagnose COPD and confirm it and see, how bad the FEV1 is when they are totally at their baseline in the outpatient setting. If you do it in the hospital, you get a false idea of how bad the disease is because they recently had an exacerbation. So no room for that. If you're doing it for that reason, in the hospital to see how bad the disease is, it's a wrong answer. You got that one wrong, because you have to wait until this patient gets better and then do the pulmonary function test and then say, okay, yeah, this patient has, X amount of disease. Always do PFTs in COPD patients. Schedule for lung surgery to assess the extent of disease. Remember, we started this talk with the pulmonary function test and saying a lot of patients with lung disease, when they go for surgery, take a patient with cancer, they're smokers, so they have COPD. What do you have to do before you decide on surgery? Well, you have to do pulmonary function tests. You have to have an FEV1 or FVC above 50% of predicted to be able to do adequate surgery for lung cancer. So very important, a lot of the patients with lung cancer, unfortunately, even though they have presumably resectable lung cancer, you can't do surgery on them because they have extensive chronic obstructive lung disease. So here are a couple cases. So a 67-year-old woman, this was the case before, with COPD, is evaluated for chronic dyspnea. She denies fever, but has productive cough. Her medication is inhaled ipratropium. She has 32-pack-year smoking history. Her respiratory rate is 32. Her pulse is 106. She's febrile. She's cachectic. She has rapid breathing, distant heart sounds, increased AP diameter, and expiratory wheezing. So they may ask us, well, what is this more consistent with? And this is more consistent with, out of the two, it's more consistent with emphysema. Rapid breathing, cachectic, right, not plethoric, and so forth. I mean, how would I know? I would have to do pulmonary function tests. That's the only way I would know. And I would find in this patient that this patient has an obstructive pattern, non-reversible obstructive pattern with a decreased DLCO because she likely has emphysema. Now, she says to me, I have chronic dyspnea, and I ask her, is the ipratropium, good for you? Are you doing well, right? And, what do you, are you feeling good with that? And if she says, okay, fine, I don't do anything more. If she's not, then I may add, if she's having a lot of symptoms, I may add a beta agonist. And if that doesn't do it, then I may consider using theophylline. I'll be careful with it, but I'll consider using theophylline if nothing else works. Now the other thing is, she says, hey doc, can I do something here, to, so make me live longer, to increase my survival? And the answer is yeah. She could do two things. She's got to stop smoking, that's number one. And number two, what are you going to do? You're going to assess her for home oxygen. How are you going to do that? In the outpatient setting, when she doesn't have an exacerbation, right, you're going to check her oxygen. If her PaO2 is less than 55 millimeters, right, then she gets home O2. She doesn't have any evidence of cor pulmonale here. So I don't say between 55 and 59. I said 55 or less. So that's what I would do in this case. So we talked about this. We talked about the PFTs show evidence of non-reversible obstruction. She wants to know how bad her lung disease is. You check an FEV1 because that's the best way to measure how bad the disease is. And then how do we treat? We said we give the patient ipratropium. That's what she's getting already. She gets assessed for home oxygen. We tell her about smoking cessation. And then, of course, I forgot to tell you this about the vaccine. She has to get the vaccines. The basic vaccines are the pneumococcal vaccine every 5 years or once in a lifetime, and then the influenza vaccine every year. She has to get that. The Haemophilus influenza vaccine, most of these patients have received that already, but that's the third one you got to make sure she gets. And then a couple questions about using a beta agonist. I told you, be careful about using a beta agonist with ipratropium. It causes bronchodilation, but it causes also tachycardia. And we said, well, what if she still has symptoms beside all that? Then we think about adding theophylline. But the question mark in these patients is make sure she doesn't get any toxicity from theophylline. A 72-year-old man with chronic bronchitis comes to the emergency room with dyspnea and cough over 2 days. COPD has been stable until recently with a prior hospitalization 8 months ago. His past medical history is hypertension, dyslipidemia. He has a social history of 42 pack years smoking, medication, inhaled ipratropium 3 times a day, lisinopril, hydrochlorothiazide for his blood pressure, simvastatin for his cholesterol, and he gets continuous oxygen 1 liter per nasal cannula. So right away, when I see this guy, what do I know? I know he has severe disease. How do I know he's got severe disease? This last line here. He gets continuous home oxygen. So I know that his PaO2 is less than 55, or he has cor pulmonale and it's less than 59 or less. So he has severe disease, and when he comes to me and he says, I have dyspnea and cough over 2 days, I think about admitting this guy right away because he has severe disease. Remember we said be careful about people on home oxygen. They have severe disease. Hospitalize them and watch them closely. Now, if I hospitalize this guy, what's he going to get? Well, he's going to get his bronchodilators, but now I start to manage him a little bit like asthma because he has an inflammatory process going on just for the exacerbation. So I will put him on systemic corticosteroids, prednisone, methylprednisolone, a spurt of steroids. And then, remember we said, even though his chest x-ray is normal, what else are we going to use on this guy? We're going to use antibiotics despite his chest x-ray being normal. So that's how we manage this guy. Admit to the hospital, give him steroids, bronchodilators, give him enough oxygen for 88 to 92% saturation, and then give him antibiotics. We said that. So a little bit more on this guy. A respiratory rate is 22, his pulse is 126, he's afebrile. His physical exam shows distant heart sounds, increased AP diameter, expiratory wheezing. His JVD is 10 centimeters, so he has JVD. His peripheral edema is 2+, so he has cor pulmonale along with that. So they're asking us specific questions. What is the next step in this patient? So the next step in this patient is to remember he's hypoxemic, right? So he has dyspnea. Check an oxygen on him at room levels. Check an O2, check an ABG, and then put him on oxygen. And after that, what are the first steps after that? You put him on oxygen, give him a bronchodilator. So they feel better. What are the first tests to do? Well, we did the ABG already. So that's one of the first things you do here. And then a couple more things. You do a chest x-ray to make sure this patient doesn't have an infiltrate. Now, listen to this. I'm going to go back a slide here. Look at this. His JVD is 10 centimeters here. Okay? Now, this is important because you say, wait a second, maybe, he's got cor pulmonale. Maybe he has congestive heart failure from something else. He has hyperlipidemia, he has hypertension. So one of the first tests to do after you do the ABG, after you do your X-ray, is to do a BNP. Remember we said the natriuretic peptide, right, is an important test to do when you're trying to decipher when a patient comes in with dyspnea, is it from the heart or is it, something else? So a normal BNP in this guy would tell me, yeah, this is all COPD exacerbation, and I would treat him right away for that. If the BNP is elevated, then, I start to think about, heart failure and stuff like that. Maybe he's got a COPD exacerbation, but, he's got heart failure on top of that. Why will this patient get admitted to the hospital? The answer is because he has severe COPD. How do I know he's got severe COPD? Well, because, he's on home oxygen. Why would an EKG and BNP be particularly helpful in this patient? Both because of what we talked about. It lets you evaluate for other causes of dyspnea in this patient, other than lung disease. If the chest x-ray shows no evidence of pneumonia, do we still start antibiotics? And we've answered that already. We said yes, because even if the chest x-ray is normal, there's still benefit in these patients. In this case, when would you consider doing PFTs during the hospital admission? And the answer is never. That's the answer, because there really is no benefit to doing PFTs during the hospital admission. It's a trick question, right? There is no reason for that. It's not going to tell us what this patient has. We'll wait until the patient gets better, and then we'll do the PFTs to find out how severe the patient's disease is. Or, let's say this guy never had PFTs before and you want to document, chronic obstructive lung disease, do the PFTs later when the patient gets better to document COPD, but not in the hospital, not in the acute setting, because this patient has an exacerbation. You're not going to see anything relevant. A 37-year-old man comes for the evaluation of elevated transaminases that were found on routine labs. He's got COPD for over 2 years. 37-year-old guy. Right away, that's the first thing that hits me, that this guy's kind of young. 10-pack year smoking, quit 7 years ago. Medication, inhaled ipratropium 3 times a day. Respiratory rate 16. Pulse 92 at febrile. Mild expiratory wheezing involving the lower lobes. A CAT scan shows a lower lobe emphysematous changes. Now, this guy came in for transaminase elevation, so I want you to keep that in mind. And now, what struck you is that his past medical history is that he's got COPD for 2 years. Of course, this guy has alpha-1 antitrypsin deficiency. You have to measure alpha-1 antitrypsin levels to make a diagnosis on this guy. So young patients, especially with a short history of tobacco, especially if they have transaminitis, you have to think about alpha-1 antitrypsin deficiency.